facial muscles for speech and feeding, why balance is crucial. Let me introduce you to my friend Hallie. And I know Hallie pretty well, and I know Lily pretty well. She and I were telling jokes the other day together. But I'd love for Hallie to take a minute and just tell all of you about what she does. Hallie, take it away. Just tell everybody all about you for me.
Sure. And it is 9 o'clock and she's been up since early this morning. So you might see a little wiggle worm over here because she's
That's okay.
All right. So okay, so I'm Hallie Balkin, and I'm the owner of Little Sprout Therapy in Metro Myo, and we do treat the Maryland, DC, and Northern Virginia area. So that is why it's probably confusing as to remembering where I personally live. But I specialize in pediatric feeding and myofunctional therapy. I do work with the pediatric crowd as well as the adult crowd for Myo. And I also specialize in pediatric feeding therapy with infants and babies who have tethered oral tissues and are, undergoing frenectomies. And so we do a lot of pre and post-op frenectomy care and feeding therapy, as well as myofunctional therapy surrounding all of that. I'm also the creator of the Feed the Peds course that we recently launched. And yeah, so that's a bit about me.
That's fantastic. And you and I knew each other, I think, on Facebook first, but then you came to one of my classes in the Virginia area, and that's how we got to know each other over the years. And since then, I've referred a lot of families to your practice and gotten to know Lily a little bit better. But she's our star tonight because can you tell us a little bit about Lily's history?
Absolutely. And if you're familiar with my podcast, and you probably heard all about it, but we'll give you a short little synopsis. So Lily was born with lip and tongue ties. We had a horrific nursing experience, but I was stubborn, and we nursed till she was 13 months, even though it was very painful for me. And she was that kiddo who never got above like the first percentile weight-wise. So I had her checked for ties. Everyone said she was fine. And then I went to my Myo course, and lo and behold, came home, assessed my own child, and went, not so fine. We've got a pretty serious lip tie and tongue tie and a high narrow palate. And, once you put your Myo eyes on and you see these things, you just can't unsee them. So what we also realized was that she started to develop some very selective eating habits. And she ate a lot more as a young child. We did not have trouble transitioning to solids, thankfully, but then became very picky around 15 or so months of age. We're getting more, we do experiment a little bit now these days, but she's also been in an ALF appliance with our airway-centric dentist since August of 2019. And we are getting some palatal growth and expansion there, which is great. So we did have her tongue tie released, not her lip, but her tongue tie was released at 24 months. And we did a little bit of pre-op, not as much as I would have liked, and we did a little bit of post-op, again, not as much as I would have liked, but she did gain a lot of function. So now we're working on rebalancing all those muscles. She is doing Myo with me, and we're trying to track our journey just with little snippets of some of what we're working on my Instagram, if anybody wants to ever check that out. But it's Myo with a 4-year-old, so it keeps us on our toes.
That's great. Thank you. That's such a good explanation of our little star here. Hey, Lily, do you have one of these, sweetie?
Should we turn it on?
It's our fairy wand, right? It is a throat scope. And tonight's event is sponsored by Throat Scope. And I want to make sure that everybody knows before we jump right in here that tonight Throat Scope is giving away a starter pack, which includes the lightsaber itself, is what I call it, and an extra blade in the back and 50 additional blades as well, because these are recyclable. They're one-time use only. And we're going to be showing you with a throat scope a little bit more about Miss Lily and her beautiful mouth. Real quickly, Hallie, can you explain to especially the parents listening what an orofacial myofunctional disorder is? That's a mouthful. What is that?
Yeah, so we'll an OM for short. Basically, it's when there is an abnormal lip, jaw, tongue. I also include the cheeks position during rest or when swallowing or speaking. And so we also may see some prolonged oral habits as a result, like thumb sucking or finger sucking, and there's other ones as well. But for Lily, for example, just as a quick example, we did see that she had a preference for the side she chewed on, and so there was actually an imbalance in the strength and in the use of her muscles on one side versus the other.
I really think of oral facial myology treatment as almost like yoga for the face, but it's not just facial muscles for everybody listening. It has to do with respiration and posture as well. So I know one of the main goals of myofunctional therapy is not only overall body posture, but also tongue posture. Mm-hmm. Can you tell us a little bit more about that, please?
Absolutely. So I always tell parents that there's generally three main goals that we're working on, and that has to do with the oral rest posture. And so what we want is we want lips to be nice and closed. We don't want an open mouth. We want the tongue to be resting up in the mouth, and that looks different for some people. Some people have just the front third of their tongue resting up on their palate, behind the teeth, not touching the teeth. It's about 2 to 3 millimeters behind the top central teeth. And then the teeth are usually, you can talk in 1 minute. The teeth are usually about just maybe a couple millimeters apart. Some people do rest their teeth together and others have them slightly apart. So that's the oral rest posture that we want. That's the main goal. The second, we're going to do them in 1 minute, okay? The second main goal is where everything is resting when swallowing, right? So oral prepping the food, but then also swallowing. And then oftentimes our third big goal in myofunctional therapy is making sure there are none of those noxious oral habits, which basically means thumb sucking or anything going into the mouth or the mouth doing anything other than that nice oral rest posture.
Right, right. Lily. Okay, ready?
Ready?
Grab your fairy wand, wave it, see how it lights up? Abracadabra. Oh, you did it.
Look, you changed it.
Oh my goodness. Tell us a little bit more, and what can you show us inside that adorable little mouth there?
What should we show them? You want to show them your mouth or the top of your mouth? Here, bend all the way back. I won't leave off. Good. And then we're going to light it up there so you guys can see. So she had a high narrow palate, wrong way. There we go. Thank you, Lily. And this is really nice. I use these in all of my orofacial myofunctional evaluations actually, because I don't need to depend on the camera flash when I'm using this. So it's really a beautiful thing. I can use like my iPhone to document pictures with the throat scope. And it does a really nice job of showing me what their palate looks like. Also, is the tongue bunching in the back? Is it laying low in the mouth? Is there any scalloping on the side? I use it for all of these things to really illuminate what's going on so I can see better. What else would you like to show?
Wow, Lily, I can see the whole inside of your mouth. Let me see one more time, and let me find out what you had for breakfast. Can you lean back? Let me see.
Good, and bend back a little bit. Or you're giving us a bowl. Good.
Oh, yeah. Oh, yeah.
So we can also
see what you had for breakfast.
What'd you have for breakfast? You forgot. It was long ago.
Was it pancakes?
We had
I thought so. I could see them in there.
So sometimes you guys will see. Sometimes we also can get a really good view of the tonsils. See it coming out? Now we're bunching up too much in the back.
You could see them really well when she leaned back. It really lights up the whole palate and the back of the throat. There you go. Wow. She's so comfortable with it too. The kids love it. The kids love it. Can you talk to us a little bit though about the difference between form and function? Because I always talk about that even with a tethered oral tissue, that what it really comes down to is it impacting function for speech or feeding. I know we have a lot of parents, again, listening as well as professionals. When parents are asking you about, well, what does this have to do with feeding, eating, speech? That's what we're talking about when it comes to function. What do you often share with them, and what do you often see in your practice?
Absolutely, and that's a great question. Are we done with her? Can I let her go?
I think we are done with her.
Take that out with Papa. Go on, go take that and show Papa, okay? Go ahead. Why? Because you're all done. Or you can stay. You can stay. Sit here. You didn't do your exercises? Okay. Well, maybe you can show us one in 1 minute, okay? Mama's going to talk about form versus function. So this is one of my big topics that I like to educate people on, actually, because, you know, you can look at anybody's mouth, and if you looked at my mouth, can I borrow your throat scope for a second, Mom? You know, some people might say, you have a tongue tie. I actually had mine released, but it was really hard for me to do my own post-op because my mouth, just the way my mouth healed. So I had some reattachment. That said, I've gained a lot of function, and I'm very functional now. And so just like Lily, hers is very elastic. So you can still see that frenulum, and a lot of people have a frenulum regrow a little bit after a procedure, depending on if you had a frenuloplasty or a frenectomy, or, you know, there's various different forms of procedures I've done. But what we're looking for is not what it looks like after the procedure or even before the procedure. We're looking for function. If function is impaired, then that's when therapy is warranted. And when we say function, we mean things like, is speech impaired? And for speech, for example, I get kids who've been in speech therapy for 5 years, 10 years, 13 years, and they still can't make certain sounds. And so I look under the tongue, and if there's something there, you know, we might do a couple weeks of therapy. If we feel like we're kind of hitting a wall and they've already been in therapy for a long haul, you know, function is impaired. So, you know, same thing with feeding. We get a lot of kids. I've had a lot of kiddos who just have trouble with textures, and nobody can seem to get them over the hump. They've done the therapy, it's not working, and function is still impaired. They still cannot become more adventurous with the foods no matter what they do. And sometimes that form is impaired and is impairing the function. And because the function is impaired, we are now going to address it. So that's where we talk about form versus function. Now, sometimes I've had babies in my office, for example, that look pretty tongue-tied. They almost look like they have a heart-shaped tongue tie, meaning it's pulling down the tip, but there's no impairment with their feeding. They're feeding well. Mom's not describing any symptoms. You know, there's no current concerns. So we're not going to treat that because function is good right now. Are we going to maybe pay attention to that later? Yes, but for now, baby's okay.
I think that's such a good point when you said right now. Mm-hmm. We're just going to keep monitoring and making sure, because what we don't want that child to do is develop compensatory methods of eating. So a lot of parents will often say to me, yeah, but you know, she's eating pretty well. But then when I watch the mechanics of it, I'm actually seeing how that child's face is going to begin to change over time because they're having to work more on one side than the other. And we have to remember that these beautiful children, their face is slowly elongating as they breathe through their nose, hopefully, and begin to build up this musculature. It's very different from an infant little round face to a toddler face to a preschool face to eventually an adult face. And we have to be careful that we maintain some semblance of balance there, or the face can actually torque. And the rest of the body, in my personal opinion and my professional experience, will sometimes torque too. It's not unusual for me to see a child with torticollis, which for parents listening is a tightening usually on one side of the neck. And the rest of the face will actually start to change as well. But the parents may not see it unless we take a picture straight on, and then we look at the picture or do some measurements. And then all of a sudden it's like, wow. I personally have a really asymmetrical face. I don't really know why. It doesn't get in the way of me eating. It definitely doesn't get in the way of me eating or speaking. But I think if maybe it had gone a little bit more than it did, I think it would have. So it's a matter of having a professional like yourself monitoring the child as they grow to ensure that those secondary issues don't arise as a way of compensating for typical function. Absolutely. For sure. Did Lily want to show us a couple exercises? I heard her say that. Before we do, Lily, we've got to take our throat scope one more time. We're going to wave our fairy wand and we're going to say abracadabra.
Abracadabra.
You did it.
Woo. You're a magician.
I'm going to do it again.
Okay, show me what you can do with your throat scope. Have mommy walk you through some exercises and then we'll do it again.
do you want to show them? Can you show them how you do your palatable suction? So we're going to suction our tongue to the top of our mouth.
I forgot what it looks like.
Oh, Hallie, I can hear Lily really well, but not you as well, just FYI.
Let's see why that. Can you hear me better now?
Now I can. Thank you.
Shift the microphone. Here we go. All right, so show them. I'm going to hold the light so they can see what you're doing. Lift your mouth up a little. So she's suctioning her tongue up to her palate, and that's one thing we work on because we actually do that when we're swallowing. And so that's something we.
So watch this.
So now what she's showing you is what we call a posterior release. And so she's going from that suction into what we call tongue to spot, which is another big one in therapy. And that's where we learn to put the tip of our tongue up, right? What we call the alveolar ridge. It's a little bumpy area right behind your upper central teeth. Not touching your teeth, about 2 to 3 millimeters behind. She's also now advancing into another exercise.
One in my mouth.
She's showing you how she can pull water onto her tongue and swallow it with her tongue suctioned to the top of her mouth. Oh no, you're not. And now she's showing you how it's suctioned into a bowl and not falling out of her mouth. So she's got really good control over the water.
Wow.
So she just went through about, 7 weeks of therapy in about 30 seconds. No, but this is really important because some of what we're saying is we need to gain function, right? We just talked about that. And so what we work on in myofunctional therapy is very functional, and our goals are to have proper oral rest posture, proper posture when drinking, eating, swallowing. And so that is some of what Lily was showing us, right? Are you all
That's fantastic, Lily. You did a great job. Are you going to stay with us or are you going to go see Daddy?
Stay with.
Okay, cool. That's fantastic. All right, super. Also, we were chatting a little bit, Hallie, you and I, because we both have such an interest in feeding, and that's all I do, and I know you do that and more. I personally get a lot of kids on my caseload who never had that tongue tie assessment from day one, who end up on my caseload and they're in kindergarten, they're in first grade, they're in second grade, they're not breathing well. And what it really came down to was lip and or tongue tie, or I should say it backwards, tongue and or lip tie, actually. I'm wondering what your personal and professional experience around that is. And do you have a theory around that the way I do, that I really think it's very much related, highly selective eating for many, many children, not all. There's a lot of reasons that you become a selective eater, but definitely if function's impaired and you're having trouble breathing, because breathing is everything, that you tend to limit the repertoire of foods that you'll experience because you go with what's safe.
Yeah, absolutely. Well, I've got 2 of my own theories, and I don't think there's necessarily research to back any of this yet. So if there's anybody who wants to do the research, let me know. But I think it's twofold. So if you're going to say, okay, Mama can focus. I'll let you go, Papa. Okay? Okay, so go to Papa, please. One, okay, 2 stars. Okay, 2 stars. Okay. All right. So with what I see with a lot of these kiddos, because you're absolutely right, I see the exact same thing, is that if the tongue is stuck on the bottom of the mouth, right? Because we talked about how we want it to rest up in the mouth. So if it's stuck at the bottom, where we're tasting things, where food hits our tongue, and what we can manage and move around in our mouth to the molars to chew is impaired. And so if we're not tasting things where they should be tasted, I think taste buds do change over time with age, but also just in general. If they don't fall where it should fall, it might alert things. And if you can't move it off of those taste buds and move it over, well, how good does that feel or taste? Not such a great experience. So then you kind of learn that maybe you just like the more bland foods a little bit better. That's one piece of the puzzle for that's one of my theories. The other thing is also if you can't move food around and you have this imbalance in the oral musculature, then it's very hard to chew and break the food down, right? So I get a lot of kids who like more bland foods, can't chew a grilled piece of meat. They can't, they really go for the things that either break down and melt very easily in their mouth or that are just softer.
Absolutely. I agree 100%. And I think, well, I know for sure, we know this for sure, that the more you stick to certain foods, whether it's bland, or I even have some kids who go for super spicy, I think because they can feel it better in their mouth.
Yeah.
But the more you go for one category like that, the more you stick to one category, because it helps you feel safe. It moves in the same way in your mouth, and it's familiar. And when we start to get nervous about trying new foods, what makes our anxiety go down is sticking to familiar. And so when we're looking at the whole child and we are considering not only medical issues, but also structural issues like a tongue tie or, other issues in the mouth, even a geographic tongue, for example, can influence picky eating. Large tonsils are another great example, a crossbite, etc. The way you swallow, we could go on and on. But when we're considering that whole child, we really want to, as I'm just going to revisit it one more time, monitor that kiddo closely, do a period of therapy to see if we can help. Oftentimes, especially with that very obvious tie, we're going to discuss with the medical team, and the parents are going to make the final call, of course, whether or not we should just release sooner than later, possibly doing some pre-op exercises for that child first. I have a kiddo like that on my caseload right now. So I just really want to stress to everybody listening that I think what Hallie's doing a beautiful job explaining, and if I can just summarize it, is that what it comes down to isn't how things look, unless it's really obvious, right? Like severe tie, you couldn't miss it. Clearly that child probably should be referred to, possibly get a release. It's not our call. But I don't know the percentage, but Hallie, tell me what you think. I think most of the kids who end up on my caseload don't have the obvious ties, because the obvious ties got taken care of when they were a baby. It's the other 75%, in my personal opinion, that end up with being highly selective eaters, having difficulty with speech, having some other diagnoses that comes into play that maybe actually isn't as big a part of the piece of the puzzle, I should say. What do you think about that?
So I've become known as the tongue-tied lady in my area. And I love it. I love working on these cases, but I do get those babies who sometimes are really obvious and everybody has missed them. But I also get babies who've been released, but not released enough, or they release the anterior part, but not the posterior part. The majority of my preschoolers on up are like you described. They are the kiddos who have been missed or nobody even bothered to look. A lot of them might have some pretty thick, or severe posterior ties, but nobody knew how to assess for those.
Right.
And yeah, absolutely. I 100% agree that is a lot of what I see. And, you mentioned a lot of reasons why these kiddos may be those pickier eaters. And one thing you mentioned earlier was airway. And I wanted to bring that up again as well, because that ties back into my theory of what you can taste, right? If you're mouth breathing and you're congested, you also don't taste your food very well. And so you either need, like you said, sometimes you need those higher taste foods, those spicy, heavy, seasoned foods, or sometimes you just go completely dull because you can't taste food anyways. So yeah. The airway and how children are breathing absolutely plays a major role in this as well.
Definitely, for sure. I know that we've got some questions, and I'm going to pop one on the screen here. We've got Daphne here. I love her. She always has really good questions. Daphne asks, how would you recommend finding an oral myofunctional therapist? And would you recommend therapy for pre and post tongue tie revision? Hallie, I know you got the answer off pardon the pun, the tip of your tongue. So you take that one.
Yes, absolutely. So there are various ways you can find a myofunctional therapist. If you're already working with a therapist, like a speech language pathologist or an OT, you might ask them. They might know somebody in the area. If not, you can always go to the IAOM website, and that's the International Association of Orofacial Myology. They have people who have gone through the right coursework listed. There are other organizations as well, but I know for sure that there's a directory there, and that's the certifying body that certified me. As far as recommending therapy for pre and post tongue tie revision, absolutely, 100%. I'm a big proponent of saying yes, 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 all of the time. And just to give you an idea, in my work, a lot of the therapy that we do in the first 3 to 4 sessions actually overlaps with our pre-op program. So it's not like we're wasting time. Sometimes if a case is borderline, it will help us decide if that case actually needs to be referred for a release provider to take a look and decide if a release is needed. And sometimes, I might go, ooh, I think we definitely need that consult. So yes, absolutely the pre and post-op therapy.
Fantastic. We've got so many questions popping up here. Carly wants to know, what is the youngest age that you recommend for myofunctional therapy?
So traditional myofunctional therapy, we generally recommend age 4 because the types of things that we're asking a child to do, or an adult to do, because we do this with adults too, you want to have a cognitive level of a 4-year-old to understand and to carry out those tasks. That said, there are things that can be modified for younger populations, and there are other types of myofunctional therapy that can be done in the younger crowds, but oftentimes that looks like feeding therapy and pre and post-op crenectomy or cranialoplasty work. So, really working, depending on the age, if you're talking about under age 4, you really want to work with a speech language pathologist oftentimes who is a feeding therapist and also has been trained in myofunctional therapy and is familiar with tethered oral tissues, and then you'll know you're talking to the right person.
I can't stress that enough. And just my own personal story as a feeding specialist, speech language pathologist, I took the training from the International Association of Orofacial Myology. I've actually taken it twice. But I am not certified because I'm so busy doing all of this fun stuff that I just can't handle more clients for that reason on my caseload. What I do, and the reason why I took the courses, is because I wanted to understand facial development in terms of balance and how it would impact speech and feeding, exactly what we're talking about here. And then what I did is, now what I do is I refer to someone who's certified like yourself if I think they need a course of orofacial myology treatment. But what's so great about it for me is I know what to screen for. I know how to incorporate that knowledge into speech and feeding therapy. And I know I just keep a much better eye on these kids as they grow. So especially for anybody who's doing early intervention, I highly recommend taking courses in orofacial myology because it just makes you a smarter therapist, to be honest with you. And I can say that because I've done it, and where I was before the courses versus where I am in terms of knowledge now, it's a world of difference. Mm-hmm. Yeah. I mean, the more we learn, right?
Yeah. I mean, I came home and I jumped right into it, and it completely changed how I was treating all of my patients, even kids who did not need myofunctional therapy, because it had me look at things completely differently.
Speaking of birth to 3, my sweet friend Marnie is here. Hi, Marnie. And she says, so good to join you tonight. The throat scope looks like such a great tool. I primarily work in the birth to 3 population. Can the scope be used with infants? Hard to tell if it may be too large. Marnie, I've got a couple good videos on that on my YouTube channel. I have a whole playlist that's all about the throat scope. But yes, definitely. And just to give you a couple quick tips, and I'm sure Hallie's going to have some too here, is that I often don't go directly in. I tend to use the throat scope to illuminate more from the side on an infant, or sometimes even this way, depending on that baby, because I'm using my other hand to support that baby's head too. Absolutely. Once you start using it, it's kind of like, where's my throat scope? How about you, Hallie? What are you finding? Because you work with a lot of infants.
Yeah, so oftentimes I'm very lucky because mom and dad are both parents, or mom and another caregiver will come. And so I have extra sets of hands. And so what I will do is we put baby in 2 of our laps, and we will do a tongue lift, but I'll have the other adult actually hold the throat scope if they can and take a photo, throat scope one hand, photo other hand, so that we can document what's going on in baby's mouth. And yes, absolutely. We don't usually go all the way in. We might bring the tip like closer to the lip here, and because baby's mouth is smaller and there isn't so much getting in the way,
right,
it does illuminate things a lot better, especially when they don't have their teeth yet. It's easier to get things lit up.
That's great. Marnie, it's such a good question. I'm glancing at Hallie at the same time, and all these questions that are pouring in on the side of my screen. So everybody, please bear with me. If you're wondering why I'm looking to one side, it's because I'm trying to catch these questions so I don't miss anybody. Let's see. Oh, this is a nice comment here from Sabrina. She says, I've been wanting to use some throat scopes in my oral mech exams. Thank you for sharing the device and implementing it. It really does make a difference. And Sabrina, on my playlist on YouTube, you'll find how to do an oral mech exam using your throat scope. So be sure to check that out as well. Thanks for that nice comment. That's so sweet. All right. Yes, here we go. Here's a question we get a lot. Do you recommend infants having a tongue tie revision to prevent future issues rather than waiting and seeing? It's a little bit of a gray area, isn't it, Hallie? Why don't you take that one and I'll look for another question. It's a great one. Thank you, Nicole, for mentioning that. Hallie, what would you like to tell Nicole?
Common question, and it's definitely a hot topic in the myo and feeding world. Depends who you ask as to how they will answer. My opinion on this and my experience on this is similar to what Melanie and I actually discussed before. We want to look at form and function, and we want to, sometimes parents will actually bring a child in because it looks like they have a tongue tie, but they think that the function is okay, but they just want baby to be checked anyways. And then I get in there and I go, I actually noticed that baby, that torticollis, they have a side preference and things are tight on one side, and there's actually other things that are being functionally impacted outside of the feeding that the parent is, initially concerned about or not concerned about. So we do that full body postural, look. We talk about for a baby specifically, we talk about, is baby gassy? Does baby, there's a lot of other symptoms that can be present that a lot of our families do not realize are related to what's going on in the mouth. And so we look at full body. Is baby refluxing? Is baby on reflux meds? Although baby have a milk protein allergy, how we rule some of these other things out, these gastro issues and airway issues. So, that's one side of the puzzle. The other side of the puzzle is if baby appears to be completely fine and function is not impaired, we might just monitor baby. We might want to do some check-ins in a couple of months and make sure, because so much development happens in the first 2-3 years of life.
Right.
We want to make sure baby is staying on track and that child is truly moving from, breast milk or formula to puree and solids and upwards, and not falling off the ladder at any point of the way. So it really, it depends. But monitor is my big thing there.
Hallie, Lily is about to fall asleep. Would you like to pass her off to your husband and I'll take the next question?
Sounds good. I'll be right back.
All right. Sounds good. We've got a good one here from Melody. Good night, sweetheart.
Good night, everybody. We'll be right back.
Melody asks, if you think that function is impaired, what are the steps to get some kind of evaluation? Is that your primary care provider, referral somewhere else, or does the age matter on how you get it evaluated? So the speech therapists ideally are trained to do an evaluation in terms of tethered oral tissues, and we get additional training outside of graduate school for that. So not every speech therapist is trained in it, but we're working very hard for all of us to get to that point through messaging, through articles that I've written for the American Speech Language Hearing Association, and through networking and building knowledge through the International Association of Oral Facial Myology. So Melody, I have kind of a gray answer there for you, because ideally, in a perfect world, I want you to be connected with a speech language pathologist who, even if they're not certified in oral facial myology, they know how to do an exam for tethered oral tissues, and they've gotten that training. They then may create a team where they refer you to a pediatric dentist, an otolaryngologist. Occasionally it might be a pediatrician, but usually it's the first two. And as a team, we'll look at that whole child and determine whether or not you as the parent would like to take the next step, which would be a release. And every single child is different. And we take a look at so many different factors. Then, if that therapist is trained in pre-op, prepping that child for the procedure and making sure that we've done all we can to get them ready for the procedure and the stretches or exercises after that, If they're not trained in it, they need to refer to someone who is. And that's often a certified oral ophtalmologist or a speech language pathologist who, again, has taken additional training. So it's tricky. And so what it really comes down to, and I'm so glad you asked the question, is the parents have to ask, what's your training in this? What part of this will you do? How will you guide us? And do I need to see a specialist while I'm also working with you? That's usually the way I go about it. How about you, Hallie? Tell me your input there.
Yeah, no, I 100% agree. And I know her original question was about, do we go to a PCP? And most are not trained in this, right? So that's why it's so important. And they will sometimes look and they will tell you, oh, no, they're fine. They can stick their tongue out. I know we hear that. So it really is important. And we're not putting down our PCPs. We love them, but they're generalists. They're often, and there are some actually that have taken courses and can assess, but that's more rare than it is normal. So, or the norm, I should say. So it's really important to know who your specialist is and to know that they have the proper training, as Melanie already explained.
So on that same note, Brianne, who has a beautiful picture with the baby here, I love it, says, looking at a kiddo's mouth, can't see tonsils due to the tongue. Tell him, stick out your tongue and say, ah. The tongue moves forward slightly and he vocalizes, but I still can't get a good visual of the throat. Any thoughts? He can close his mouth and protrude his tongue fairly far, almost like the base of the tongue can't relax enough to allow for visualization. Hallie, you're nodding, so you go ahead.
Yeah, so I don't know if you saw that with Lily, actually, and that's something that we're working on. Depending on what's going on, and so first my question would be to Brianne, what is the concern? Is there a concern about the tonsils? Is this a child who gets sick a lot? Is there open mouth breathing? Is there snoring present? Can you hear your child breathing? Is it audible? Because that's when we start to become a little bit concerned about, are the tonsils a little enlarged or the adenoids a little bit enlarged? And the school of thought of even doing anything about it is also very split because they can grow back. So there are a lot of people who do not like to remove them. But what I've learned through a lot of breathing exercises we can do, as well as myofunctional therapy, is that there are ways that we can train the back of the throat and the back of the tongue, and we can actually bring that tongue down over time. If there's a severe tongue tie, posterior tie, that may prevent that. But I've been very successful, especially with adults, in getting that tongue lower in the back of the mouth through various exercises.
Sometimes I find that it's a crazy term, but it's the humping back of the tongue. They kind of pull it back, right? That's protective in nature. So it does take a little bit of time for the kids to feel comfortable getting their tongue to relax. And Brianne, on my YouTube channel, under the Throat Scope playlist, you'll see a presentation I did on how to help kids open their mouth if they're hesitant to do that, but also how to open their mouth wider. And I do find that if we can really get a child to open up wide and look up slightly, as you had Lily doing, and then relax, we can get a better visual of the tonsils. It can take 4 or 5 very, very gentle sessions until we get to that just right feeling where the kid goes, oh, I got it. This is what you want me to do. It's a little bit hard to describe to a little kid. So sometimes it's just a matter of gently working with them until they achieve the correct posture in their mouth so that we can visualize those tonsils. For sure. Great. Let's see. We've got another question here. Oh, Crystal's here. Fantastic. Crystal says, how do you determine that function is not interfaced with accommodation, which then changes facial growth over time? That's a great question. Hallie, what do you think?
That's a loaded question, Crystal.
Yeah, it is. Thanks, Crystal.
How do you determine that function is not interfaced with accommodation, right? So what she's basically asking, for those who are not as familiar with this, is, if there is a impairment, if our form, right, our muscles, our skeletal structure is accommodating the tongue, right? The tongue may not actually fit up there. I think most of the time function is impaired, and there really isn't a way to separate that out. I think that the function is going to also be impaired until we can deal with the form. And so that's why at the young age of 4.5, I have Lily in an ALF appliance, because we are trying to, for me to do myofunctional therapy with her and try to get her tongue up in her palate and develop these correct oral rest postures while I know her palate is still high and narrow, it's not fair because the tongue can't fit up there. So, you know, what we're doing is we actually put her into expansion first, and we made sure her tongue was not restricted for her case. And this looks very different for every different child. There's not one right way to go or one, you know, step 1, step 2, step 3 for the order of how these happen. But some kids do need some expansion first before function can improve. So, you know, I don't know if that helps at all, you know, Crystal, with what your question is. And, but yes, absolutely. The facial growth changes based on where the tongue is, but then we can't work on the tongue until we make sure that we expand the face. So it's kind of like that catch-22. And what do you address first?
And I think it really does come down to making sure that we're referring to a really well-trained, experienced, knowledgeable provider who can help us put on our detective hat and kind of figure all that out. But one of the things that I typically do, and I know you do too, Hallie, is if I see a child and I'm seeing some compensatory strategies, yet they seem to be, for example, eating fine, right? But I'm noticing that they actually are using a lot of really unusual movements to get that food down. And I'm concerned about how that may be interfaced with accommodation and function, et cetera. I will ask them to do it this way. You know, okay, let me show you. Instead of taking your tongue and moving it side to side to move the food from the left to the right like a canoe, so the kids will do this. It's like they're rocking a canoe, right? Instead, can you do it this way? Can you actually move the tip of your tongue over there? And they're like, no, because I don't know if you noticed, but I have trouble making the canoe with my tongue because I don't eat that way. But they get really good at it because they've been eating that way for years. And that's a compensatory strategy. And so when I ask them to do it the more typical way, they can't do it. Now that tells me that's impeding function.
Yeah.
So yeah, it does require quite a bit of detective work. And I think that's why Crystal's asking it and why taking courses in this is so important, because we look at so many different case studies and a lot of photos and a lot of videos of these kids.
Yeah, those photos and videos are the best thing you can do for yourself.
Absolutely. Amanda's asking a question about speech. Any thoughts about lateral lisp and rest posture? For the parents listening, Hallie, will you just tell them the difference between a lateral lisp and what a lot of parents think of in terms of a typical lisp?
Sure.
What's the difference? Yeah.
So with a lateral lisp, that's where the air kind of spills over the side of the tongue, and it makes your speech sound very slushy, as compared to a frontal lisp, where we have the S sound or the Z, the S, I should say, letter, which makes a sound, or Z, which becomes the tongue interdentalizes. It means it goes between the teeth and it sounds more like a TH. And so those are two different types of lisps. But either way, I do see both of them with myofunctional disorders.
Sure. And what would the resting posture of the tongue, especially for the parents again listening, how would that influence either one? So where would that tongue be resting?
Yeah, so when we see a child who has any type of a lisp, oftentimes the tongue is either resting low in the mouth. Again, it could be low in the mouth, just hanging down at the bottom. It might be against the lower teeth. It might be pushing against the top and bottom teeth. It might be pushing through the teeth and kind of coming forward. And when the tongue is doing that, that's obviously not in the oral rest posture position that we talked about early on, where we want it up in the mouth. We want it to, and when this is happening, this is very evident that the child does not have great control over the tongue for whatever that reason may be. And that's oftentimes, in my therapy, if we can address the tongue, we often very easily can then address the lisp.
I'm going to put one or two more questions up here, but when we're all done in the morning, I'll go through and try to answer everybody's questions as well. So Kendra has a good question here that I hear quite often. In your experience, do you see revisions of tethered oral tissues when an otolaryngologist, an ENT, has done it with blade and stitches release versus a pediatric dentist with a CO2 laser? And just to clarify for everyone, I think what Kendra also means there is it isn't necessarily the the ENT versus the dentist, what we're really talking about here is a traditional surgical release using a blade and stitches versus a CO2 laser. And I'm just going to jump in real quickly, but Hallie, I want you to too, because I think it varies according to different parts of the country. Most of the kids that I refer to, I have a couple pediatric dentists, and I have one otolaryngologist that I send kids to. It's really coincidence that they all use a laser. That being said, they've also explained to me that there are times where they will work with a colleague because they feel that that child does need a more traditional surgical approach. And it's based on what they're seeing in the mouth, the musculature, and what they believe to be the depth of the fibers, as well as other facial characteristics of the child. So in my experience, most common now, we're doing lasers. But that doesn't mean a more traditional approach is wrong. It's just often used for different circumstances. But I know that varies from state to state, country to country. What are you experiencing on your side of the United States, Hallie?
Loaded question again.
Sorry.
I love these. I completely agree with you. I actually have, and I think that there's actually a lot of ENTs typically do use a blade and stitches, the blades and sutures, and a lot of pediatric dentists or oral surgeons will use a CO2 laser or a similar laser. So that I think it's a big discussion in a lot of Facebook groups that I've been in about tethered oral tissue. So it's a great question. This has got several points to it. So number one, it's more about the skill of the provider, in my opinion, than it is about the tool that they're using, because with two different tools, you can achieve a very similar result. And so it's more so about gaining function and knowing how to gain function during the release. So having a functional release. We don't just want an ENT with an infant going in and going, okay, baby's good. Send him, because I get some of these babies, and I think that's what gives a bad rap to this, because these babies then end up needing to go to the pediatric dentist who does have a CO2 laser to get the tongue redone, to get that revision. So that's one piece of the puzzle. The other thing I'll share is that the oral surgeon who I refer to quite a lot, because he's highly skilled, he did my tongue tie, he did both my kids' tongue ties, he will use both. And so he will often start with the laser, and then he will switch and he might use a blade, and then he might suture you up. And I actually started asking him, I said, hey, you get really good results when you suture, especially our young kids, because when we suture those young kids, it buys us time and we don't have to jump right in with that post-ops, active wound care. And I know I'm going down a whole different rabbit hole here, but it's so helpful to have sutures in place. So it's not an either or. It really depends on the provider, what they've been trained in, what results they're getting, but it needs to be functional. No matter what tool they're using or who's providing the release, it has to be functional. And when I say functional, they need to be checking their work as they do the release to make sure that that tongue can go where we want it to go.
Fantastic. This is always fun for me. I do these every Monday night and sometimes on Thursdays on the Throat Scope page, because I get to see, often we have so many repeat visitors, and we've got Kelsey. She lives down in the South. I know her. And Kelsey has a good question here. She says, if a child about age 2 is extremely selective, no tongue tie, but doesn't lateralize the tongue well and prefers just one side, what could be the culprit? No developmental delays other than a delay in development in terms of movement, obviously. But gosh, I can think of like 5 of them. Do you want to go first?
Why don't you start and I'll...
Well, Kelsey's attended my courses before, and I know she knows this, but for everybody listening, you have to always look at the whole child. And you're going to be thinking about not only the physiology, and that's how your body functions. And that can include anxiety, it can include habit, it can include emotions, but it can also include things like large tonsils and a sore throat, gastroesophageal reflux disease. So we're looking at the whole child. And then we're looking at motor skills. And motor skills the fine motor skill of lateralizing to one side or the other is always influenced by gross motor stability. So it's really possible that just to name a few, this child is not lateralizing their tongue well because maybe one tonsil is a little bit swollen, a little bit lower down in the throat, and everything's being torqued a little bit. If anyone has ever experienced having a canker sore or having one of their glands swollen a little bit under their tongue because they have a little bit of a virus, you know that it's uncomfortable to move your tongue. Well, I've seen that happen before too, where maybe they have adenoid tissue behind their soft palate and it happens to be fairly large on one side. So when they go to try to close their soft palate, if I can show everybody here, I'll try to show you with mine. You can see my soft palate going up. Their soft palate actually torques because they got this big pillow of adenoid tissue back there. And once one part of the mouth starts to torque, other things start to torque as well. And then finally, there's also behavior. And if the child early on perhaps had a tooth that was coming in very painfully and they learned to chew on one side, the tongue learns to move in a certain way toward that side and habits are formed while the face is developing. So yet another thing that takes a lot of detective work, and I think it's a great question that Kelsey has. In those situations, Hallie, I always bring in somebody else. I just need another pair of eyes. I can't figure out this puzzle. And we've all been there. Doesn't matter how experienced you are. Like saying to a colleague, can you come and take a look at this kid? What do you see? What do you find is helpful, Hal?
Yeah, no, I completely agree. And I think an occupational therapist might be a good next step especially if you've done a feeding eval or a myofunctional eval with this child and you've been trying to work on it and you still can't get that tongue lateralizing. I've had a few cases where there are kids who really have a hard time moving the tongue and we have to look at, well, why is that happening? What else is going on? If they can move the tongue all over, but they're just not lateralizing the tongue, but they're able to elevate and protrude and they can suction it to the top of their mouth, but still they're not moving it side to side. What else can we look at? An OT might look at the sensory system. Maybe they're a bit hyposensitive. And as you mentioned with the fine motor skills, if there is any type of core weakness, often what we see down here, we see in the mouth. So we need to look at the full body to see what's going on. Where else does this child maybe need a little bit of support to then better support what's going on in the oral cavity? I've had kids who will use their fingers to move food around in their mouth, and because their tongue just can't do it yet. And so, sometimes I'll sit with these kiddos in front of a mirror and we'll just play funny games with our tongue and see what we can get them to do. Sometimes we'll go in and we'll do a little stimulation inside the cheek, either with a finger or a vibrating tool, and keep the mouth up a little bit. So, there's a lot of things that can be done to see if we can get that tongue moving left and right. But again, the child's 2, so be careful putting your finger in there. You might get bit. But yeah, I would just look at, maybe what's going on sensory wise, what's going on fine motor and gross motor wise, because maybe something there may be useful.
Yeah, I think one of the things that I didn't realize when I became a speech language pathologist is how often we have to wear that detective hat and literally get out our magnifying glass and try to figure out all the pieces to the puzzle and that differential diagnosis that's so important for every single child. Absolutely. Well, I have to say 2 things. First of all, Hallie, thank you for joining me. I'm so grateful to have you here, and I'm so grateful to call you my friend. And 2, I want to make sure that we also thank ThroatScope because they're the ones who sponsored this tonight. And I'm so excited that someone is going to win a starter pack. Oh, you've got the box of 50 blades. So you get a starter pack and a box of 50 blades. ThroatScope will be providing 1 winner internationally and 1 in the United States. So pay attention to your messages because as soon as we're done here, ThroatScope will be picking a winner. Now, last note for everyone listening, if you didn't get to watch all of this, you'll be able to watch it on my Facebook page, but I'll also send it to you in my newsletter this week and also on my YouTube channel. So be sure to subscribe to Melanie Potock on YouTube and go to melaniepotock.com and sign up for my newsletter, because I'll send you this video. I'll send you every single one I do every Monday and sometimes Thursday nights. All right, Hallie, thank you so much. And please thank Lily. She was so adorable.
She
And
didn't want to leave. She just wanted to hang, but
I felt bad, and she was just nodding off. And you're
I'm here, so she was done.
all righty. Thank you so much. Thanks everybody for joining us. Have a wonderful, wonderful week.